Your cardiogenic shock people, you can have these patients that are cold, clammy, they're going to be altered mental status, they're going to be in distress. Those are going to be your extremist patients. Those are going to be the ones you said are volume overloaded. They're obviously hypotensive. They have really high elevated lactates, and they're going to need some pressors and inotropes. And then you can get some gray areas where you have patients who might be tachycardic and pretty normotensive, but their body's responding to something happened. Maybe they had a massive MI. I've had a patient that has been like this before that had a large MI, was a little unstable, so he didn't get taken to the cath lab right away. He wasn't a STEMI, but had very large end STEMI. Came to the ICU to get resuscitated. When I saw him in the morning, he's had a heart rate of 130. He had a new bundle branch block. Blood pressure was like 130/80, but he was in obvious distress. He's tachypnic to 40. He had rails. He had pulmonary edema, elevated troponin, elevated lactate, worsening metabolic acidosis. And this patient was in profound cardiogenic shock, despite having a pretty normal blood pressure. And these patients, if they're normotensive like that and their cardiac output's low, you have POCUS or echo to confirm it. I'm starting inotropy on them. Dobutamine, milrinone is going to be a very good place to start. That's going to decrease that afterload for them and give them some of that inotropy for forward flow. I'll be very hesitant, and we are very hesitant in my shop, starting any inotropy, dobutamine, milrinone on anybody that's already hypotensive. Those kind of work so well in cardiogenic shock for people who have a really high afterload and a really high volume status, because it decreases that afterload and causes slight vasodilation for that left ventricle to push against less resistance and have a little help squeezing. If you're putting that on somebody that already has a MAP of 55, you're not quite sure what their systemic vascular resistance is or what their afterload is. Kind of like we said before, a patient can have as many problems as they want. You might have someone in cardiogenic shock, but maybe they were septic to begin with. So maybe they already have vasodilation, or maybe they've been in extremis for hours, which can cause a surge response in vasodilation. If you jump straight to dobutamine sometimes in these people, you're going to drop that afterload too far, and you're really going to make them more hypotensive before causing any good. So I think norepinephrine is always a great place to start for patients hypotensive. You can give them a little bit of beta activity, give them a little bit of alpha squeeze. You can get them to a normotensive state. Then we can kind of reassess how their shock's doing and if they're improving.